The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us today. The webinar will begin in 2 minutes at the top of the hour. Again, we'll begin in 2 minutes. Thank you. Hello, everyone. Thank you for joining us today. The webinar will begin in 1 minute at the top of the hour. Again, we'll begin in 1 minute. Good day and welcome to this Health Catalyst webinar. As a quick introduction, Health Catalyst is a leading provider of data and analytics technology and services to healthcare organizations, committed to being the catalyst for massive, measurable, data-informed healthcare improvement. My name is Sarah Stokes, and I will be your moderator today. Now let us begin with today's webinar, AI for Healthcare Leaders, the new AI frontier for improved leadership decision-making, presented by Jason Jones, PhD, Chief Data Scientist here at Health Catalyst. Prior to joining Health Catalyst, Jason served at Kaiser Permanente in various roles, including research scientist and vice president of information support for care transformation. He received his PhD in biostatistics from the University of Southern California in 2001, and his mission is to leverage data to achieve the quadruple aim. Throughout today's webinar, you'll be presented with multiple poll questions. We encourage you to engage in those polls as they will help to drive today's conversation forward. We also urge you to submit questions throughout today's presentation via the questions pane in your GoToWebinar control panel, as Jason will answer questions at the conclusion of the presentation in a Q&A session. We are recording today's webinar, and by midday tomorrow, you will receive an email with links to that recording, the presentation slides, and a transcript. If you'd like to stay in the loop on upcoming webinars and all things Health Catalyst, you can follow us on social media. Our handle is @HealthCatalyst. I will now turn the time over to Jason. Jason?
Thanks, Sarah, and thank you all for joining today, spending some of your time with us. This is a topic that I care deeply about, and yet it's not one that I've seen broadly embraced out there in the world. So I'll be really interested to hear your feedback and thoughts through this process. So the topic is how it is that we can think about AI for leaders in healthcare. And there are a couple things that we'll talk about. One is why is it that AI should be thought of as complementary or augmentation and not artificial or replacement. Another is to try to identify some really specific tools that you could use at your own organization, as they say at the Institute for Healthcare Improvement, or IHI, next Tuesday. And the last is to describe how your organization can move forward to implement augmented intelligence specifically for leaders. So with that, we have our first poll question.
All right,
Sarah?
Let me go ahead and launch that. Okay, in our first poll question, kicking things off here, we'd like to know, what is your role? Your options are 1, senior leadership, C-suite, or you're an EVP or above. Your option 2 is department, hospital, or regional leader. Option 3 is clinical or operational staff. Option 4 is program or large project manager. And option 5 is IT or analytics staff. We'll give you just a few moments to get your responses in there. Appreciate you being pretty quick on the draw there, everyone. And if you joined us just now, please know we are recording today's session. You will have access to the slides. Okay, I'm going to go ahead and close that poll and share the results. Okay, so it looks like 10% are senior leadership, 16% are department, hospital, or regional leaders, 11% are clinical or operational staff, 27% are program or large project managers, and 36% are IT or analytics staff.
Wow, so this is a really wonderful mix, and thank you so much. One of the things I was hoping is that it wouldn't all be those of us who are in the IT and analytics staff part, because one of the things that I've seen that can be discouraging for those folks is if they try to do some great work, take some risks, and then the people they're trying to support say, just go back and do what you've always done. That's one of the things that we'll close off with as well, is how it is that we can sort of shrink the gap between how it is that we may be able to use data and how it is that we're actually using data within our organizations today. So really, really grateful, both for those of you who come from the sort of decision support world, but also thank you so much to those of you who came as our clients and customers, those of you who need to make decisions, especially leadership decisions in health and healthcare. Okay, so the next thing that we're going to talk about is how it is that we think about AI at the highest level of leadership. After that, we'll talk about separating signal from noise and being able to achieve a future orientation, which is so critical for leaders. And then we'll close and spend a fair bit of time on what may, for some of you, be quite an unexpected application of these tools. So we'll go on to our next poll question.
All right. In this poll question, we'd like to know, on a scale of 1 to 5, how likely is your board of directors or your senior leadership team, if you don't have a board, to have a machine as a voting member by 2025? Your options are 1, 0% inconceivable. That's a great word choice. Option 2, 25%. Option 3, 50% chance. Option 4, 75%. And option 5, 100%. You are certain that your board will have a machine as a voting member by 2025.
Yeah, kind of an allusion to Princess Bride there. We know how that went, some of us.
Okay, I'm going to go ahead and close that poll, and we're going to share the results.
Yes, so many of you, most of you, the majority of you agree with it being completely inconceivable. And I love that response. And I don't know whether to agree with you or not, but you are in a really good company. This was not some kind of a random question. This has actually been surveyed. So what we have on the right-hand side here is a survey saying what's the likelihood that each of the items on this list might occur by 2025. And Sarah, I am interested in your opinion. What on this list strikes you as interesting, or you think differently about? Is there anything that kind of pops out here for you?
I mean, the driverless cars one scares me a little bit still. But them equaling 10% of all cars on US roads, that seems pretty ambitious. But there's actually a lot of really cool stuff that also scares me a little bit, but pretty cool stuff too. And the first robotic pharmacist. But I can see why people are leaning towards wearables, since we're already seeing that. So,
especially wearable clothes.
Yes, not wearable clothes.
As someone who's
those are quite popular right here.
Yes, I've personally been shocked by an electric blanket, and so this one kind of makes me nervous. But anyway, what also is interesting is look at what's at the bottom of the list, and at the very bottom of the list here, what we have is the first AI machine on a corporate board of directors. So you all who said, no, that's impossible, are in really good company. And the other thing that is worth pointing out is that it is the only thing on the list where people thought there was less than a 50-50 chance that this could happen. So why might that be? And one thing I'll point out is that surveys themselves can often tell us just as much about the respondents as they can otherwise. And who was actually responding to this? The survey was conducted among 800 executives and experts. So pretty much one of the takeaways that I have from this is that among executives, we tend to think that everybody else's job can be automated, but not ours. And how do we think about that in health and healthcare? How do we think about who our most educated and most practiced individuals are, which some of us might argue are actually our physicians, our nurses, our pharmacists, where they've spent, perhaps 12 years in school and another 10 to 20 years in practice. And where is it that we focus our efforts in predictive modeling and AI and machine learning? It's on those people. And it's not to say that we can't deliver benefit there, but why do we feel as though they're the people who need the most help? And yet somehow, if we reach the highest level of leadership in the corporate world, that now, not sure we need that help so much. So I'm not saying what the right answer is. It's just interesting to think about. And this, by the way, is a wonderful document that was put out by the World Economic Forum, and an interesting read. The link is at the bottom, and you can have the slides and check it out if you'd like to.
Before you leave that topic, Philip just asked for a clarification. Do you mean a voting member or using extended AI to help formulate decisions?
That is a great question. And that kind of comes down to how do we think about our board members, especially in health and healthcare. And I've seen them where we have healthcare organizations with boards comprised almost exclusively of people outside of health and healthcare. And there we would very quickly say, geez, how do we make sure we get that healthcare perspective as well, especially as it comes to quality and clinical and operational issues. So I did intend to mean, as I think that this survey question intended to ask is, no, it's a voting member. And how do we think about that? I mean, we have voting members, as I said, who are not clinicians. That's standard. We have voting members who perhaps are lawyers or HR professionals or in the airline industries or something else. And we don't really think twice. We actually think it's beneficial to have that perspective voting at the table. How might we think about AI? Again, not saying it's the right answer, but thank you for the question. And yes, I did mean an actual voting member. So we'll go forward. And here we have a self-driving car picture, which is a little bit scary to Sarah at the moment. But Sarah, I'm going to ask you, would you like a self-driving car?
For me, I don't know.
If it could be safe.
It's tough, right? Because you think, well, are people that great of drivers? We all have our own opinions on that.
Mm-hmm.
And could it, something operating based on an algorithm do better? Probably.
Mm-hmm.
But yeah, I think for me, I'd need to see a bit more testing. And
Okay.
I'm a pretty risk averse person. So I think it's not for me just yet.
How about once it's safe? Never had an accident.
I guess, yeah, I was going to say, what's the definition of safe?
Mm-hmm.
But I mean, yeah, then for sure.
Mm-hmm.
I think it could be good, and it would help mitigate any of those distractions or things that drivers have, right? Like that's part of the big reasoning to have a self-driving car, I think. But
so let me ask you this, because let's just pretend that that's starting to become a reality, and there's some signs that it is. And that's why your opinion matters so much, and each of our opinions matter so much now. This conversation wouldn't have really mattered 20 years ago, right? Because you could say, oh, I want a self-driving car. Well, guess what? You can't have it.
Mm-hmm. So, right. The technology doesn't exist.
Right. So now we're getting to the point where we can have a meaningful discussion. And as we think about AI, we can now start to have a meaningful discussion of what is it that we would like AI to do for us, because it's becoming technically feasible, which is wonderful. Computers are getting faster, algorithms are getting better, data capture in some respects is getting better, and that's needed for the AI to work. But now let's just pretend that you said, yeah, okay, once it's safe, I'm good with the self-driving car. So now the next question is, how would you like that self-driving car to choose where you're going? So not only is it going to drive you there, but you're going to hop in and you don't tell it where to go. It just decides and it goes. Would you like that?
No.
Okay.
I want to maintain that control over my life.
Okay, so you drop out pretty quickly, and we should have thought about a question to the attendees, and thank you again for participating. But the next question is, usually there are about a quarter of people who say, yeah, I actually don't care if it decides where to go. I don't like decisions. They're not quite as controlling as you are. But then the next question is, and I'm glad you are, because Sarah's actually running everything, so it's good she's controlling it. But then the next question is, well, would you like the car to not only drive and not only decide where to go, but actually to just go there, come back, and tell you about it?
No.
So you just hang out on your couch.
Yeah,
You
I
don't go
mean,
anywhere.
I guess I'm assuming I have the option of a normal drive it myself type car, which if I
No.
don't, then I guess I would go out. I'd be a little more amenable.
Yeah.
But in my mind, I'm picturing more like suggestions. If my car says, well, if I can tell my car I want to eat, and it says, okay, I'm going to take you to a good restaurant,
Yeah.
then maybe I'm okay with that. But it's something about maintaining some level of
And in
control.
this case, it would have not only decided to go to the restaurant, it would have gone there and come back and left you at home. So perhaps the only place you would be willing for that to be okay is if it was going to the DMV.
Yes,
Then that
that's
might be
accurate.
Okay.
Yeah, there's a few places like that.
So why does this conversation matter so much today? It matters because the technology is coming, not just for self-driving cars, but how we think about AI more broadly. And that's why this conversation matters, because we should start to think about what is it that we would like the AI to do? And that's why it's augmented and not just artificial. We shouldn't just assume that it's going to replace whatever it was that we were doing. We should think about what is it that we would like it to replace. Maybe we only want it to replace the driving, and we don't want to replace the decision making in your case. And this matters even more in health and healthcare, because so few of us would share an opinion about what is it that we want? What counts as health for us? What is it that we want from healthcare? As we apply it at the board level or the leadership level, we know every organization has its own values and its own preferences. And we should think carefully about how it is that we want to incorporate those values and preferences, and how it is that we want to retain agency over them.
You did get a funny comment from Eric Tate, who said you just described parenting.
Yes. In some cases, yes. It depends on the age of your kids, I think, and how last night went in some cases. Good comment, Eric. Okay. So let's take a look at separating signal from noise. It's something that computers do actually quite well. And we're going to first go to a poll question.
All right. In this poll question, we'd like to know, how effectively does your board or senior executive team leverage data to support future decisions? And your options are: 1, never, they don't look at data. Option 2 is not often, they're mostly looking through the rear view mirror. Option 3 is frequently, they leverage data and discuss interpretations. Option 4 is always, they are actively leveraging analytics to drive decisions. And option 5 is you're just not totally sure, or this isn't applicable. We'll give you just a few moments there. They're having to think a little bit more about this one. If you joined us late, we are recording today's session. You will have access to the slides, so please keep an eye out for an email with those items tomorrow. Okay, I think we're going to go ahead and close that poll, and we will share those results. So
thank you.
0% with never.
And that's really good, and that's actually different in this group from other groups that we've asked this question of. So either everybody's shifting, or you all are at organizations that represent different organizations from what we've seen before, and perhaps that's why you're attending today. So really impressive that half of you are frequently looking at and leveraging data in discussions. That's wonderful. Okay. So I'll be curious, although we don't ask, whether or not you're leveraging the data or providing the data or getting the data provided to you in the way that I was imagining. So challenges with leadership reporting. One is to separate signal from noise, and the other is focusing decisions on the future. So what are some examples of separating signal from noise? We might ask, is hospital A better than hospital B? We might ask, have we improved over time? We might ask, where should we set an improvement goal, and how can we be sure that the goal that we set for ourselves isn't actually in the normal variation that we would expect? And this can turn out to be actually quite difficult for human beings, and computers can help us quite a bit, as we'll see in a moment. There are organizations I know of that have set improvement goals, worked on them for 2 years, and then realized that, actually we achieved our goal, and it turns out that that achievement was in the range of normal variation. So these are real things that actually happen to us. The other is I've heard, one of the saddest things I've heard actually at an organization is that we use data in our organization to justify the past instead of making decisions for the future. And this is tricky, and it's easy because what are we looking at when we look at data? By definition, when we look at data, we have to look at something that happened in the past. And so how can we help people reorient to the future? Not, let me come here so I can slap you for your performance 6 months ago, but where do we think that we'll be in a year? And now we really start to get into sort of the equivalence of, if you had a self-driving car, would you like to go to a restaurant, and if so, which one? Are we satisfied with the performance that we think we might attain in a year? If we're not satisfied, what do we think we might change? And if we are satisfied, how do we ensure that the performance trend that we're on is actually sustainable and not on the backs of people who are going to break with their superhuman efforts over time? So again, these are the two challenges that we're going to focus on for a moment around leadership reporting: separating signal from noise, and then trying to achieve or facilitate this future orientation as it relates to decisions. And we'll just look at one image quickly, and it can be a little bit of an eye chart and requires a little bit of an orientation, so I'll just step you through it. What we're looking at is a key measure of performance, and in this case we have 7 different geographies in the system overall. Those are indicated on the y-axis. And on the x-axis we have the level of performance attainment. So for instance, the top performer in the system, this geography number 1, looks like it's around 83%. The vertical blue line indicates that the target was around, say, 77, 78%. By the way, this green bar on the right indicates the direction of good. So this might be something like, say, hemoglobin A1C control in diabetic patients, where more is better. But if we were looking at something like hospital falls, then less would be better. So in this case, being to the right is a good thing. The lowest performance in the organization is down here, and it looks like it's around about 64%, say. So we can quickly get each of the different point estimates for where it is that our geographic performance is. But there are a couple things that I'll point out quickly, and it's where it is that we get to use the same sort of AI, machine learning, statistics tools that we know and love in other places. They're in fact the same tools that we can use to, for instance, predict the probability of readmission for an individual heart failure patient walking out the hospital door right now. We can use those same tools to help us understand what's the nature of the variation that we're seeing across our hospitals. And one thing that you'll see is that these lines are different widths. Why are these lines of different widths? Well, they're of different widths because the geographies are actually of very different sizes from each other. So where you see a very narrow width up here, geographies 1 and 2 are very large. Geography 5 is very large. But this 7th geographic region is actually quite small, and that's why we're seeing the error bar be so wide here. So we're using here sort of standard statistical and machine learning techniques to figure out our certainty around our estimate, the same things that you would expect to see in any peer-reviewed publication. But here we're going to apply it again to leadership decision making. The next thing that you might notice is that some of the shapes are different. So an upward triangle means that we're statistically significantly better than the target. The downward facing triangle says that we're statistically significantly worse than the target. After that, you might notice that there are actually some different colors. So each of the triangles that we see can have a different color. Blue is indicative of the top performers. Red is indicative of the bottom performers. And you'll see there's some kind of different shades. Sarah, I only ever graduated the 8-color crayon box. Can you tell us what are these colors that we're looking at?
The bottom of the 3 looks more of a pink, like a hot pink, and then we have kind of purple above that. Both those look purple.
Okay. Thanks. And one of the things that we can do for people who, for instance, may be colorblind or otherwise our eyes are just not good enough to detect the differences is over on the right-hand side, you'll see some letters. And those letters match perfectly with the colors. And so what's that telling us? It's not only telling us that geographies 1 and 2 are better than the target, but it's also telling us that they're actually identical to each other if we think about their performance. Similarly, both of these hospitals, geographies 3 and 4, are tied with each other, but different from this 5th geography, which again is different from the 6th, and again is different from the 7th. I want to be careful here because there are different ways of figuring out, different techniques that we can use for figuring out which geographies or hospitals or something else are really different from each other. But what we're doing is facilitating that dialogue among leaders who now are not making it up in their own minds. They're not just saying, oh, well, I think geographies 3 and 4 are really the same and the same as 5. At least now we have the opportunity to see, well, the computer is making visible to all of us that 3 and 4 are similar and 5 is different. And do we agree with that assessment? And here we're talking about difference in terms of performance, but we can also, of course, bring a lot of our other intelligence to bear. Different in what other ways? Are we looking at rural communities versus urban communities, or communities where we have a very high market share versus ones where we don't, or whatever else, new leadership versus seasoned leadership, or something like that. So we can bring a lot of our other intelligence and knowledge to the discussion, but what we're asking the computer to do for us, the job that we're asking the computer to do, is to make visible for all of us to see where it is that it is seeing important differences. And we're going to extend that a little further. So far what we've been talking about is separating signal from noise. Is one geography different from another? Are either of them better or worse than the target? But the next thing that we're going to look at is try to shift the discussion away from where are we today and start to think about where will we be in the future and how do we feel about that? And those are the gray diamonds that you see here. So now, not only do we know that geographies 1 and 2 are at the top, but actually geography 1 is trending towards continued improvement, whereas geography 2 looks like it may be faltering a little bit. Perhaps more differently, we look at these 2 hospitals here, or 2 geographies here, I'm sorry, that are tied with each other today, both doing worse than the target. But whereas geography 3 might be sliding back ever so slightly, geography 4 seems to be accelerating quite quickly. And how might the discussion go differently with that information on this plot? As I indicated before, we may now say, ooh, geography 3, you don't seem to be making progress towards the target. What's getting in your way? Geography 4, you seem to be accelerating really quickly. Do you think this is sustainable? Are you actually confident that you're going to be able to improve at the level that we're seeing? Or do you feel you may need some additional support or reinforcement? And it can totally change the nature of the discussion. Again, not because the computer is right and the know-all and the be-all and end-all of all of our decisions, but because it's able to provide to us information that it's able to assimilate quite well, to do the math for us, and then that liberates us, in the case of the self-driving car, to text away if we want to, once it becomes safe. But in this case, it frees us up to have discussions of, okay, geography 3, if you're not really sure what to do next to reverse your performance, then who are you like? Who might we pair you with? Who might you reach out to learn what's working for them and apply that in your circumstance? And that's when our human intelligence tends to be much, much more valuable than calculating rates or doing forecasts or anything else. I'll leave out the description on the bottom for another time because that tends to throw people, but suffice it to say, or take a little while to incorporate, but what we're looking at here is an ability to understand the nature of the problem that the organization may be facing as a learning system and how it is that we might approach it. We'll make one other comment, and that last comment is, how does the organization feel about a small geography that not only is underperforming, but is actually not showing signs of improvement? And how do we want to think about that through the lens of our organizational values? And that's not a one size fits all. If we look at the bulk of the population of our members, they're up here, and maybe we should feel good about it. If as an organization we're focused on equity, then we need to be deeply concerned here and think about possibly shifting resources to this geography or something else, finding some way to help them. Now, the thing that usually causes the gravest concern, especially among leaders and where we could really use your help going forward, is placing these gray diamonds in here. As soon as we place these gray diamonds, people immediately say, that's stupid, that's wrong, I don't believe it. Analyst, please go back to the basement and don't bother me again. So two perspectives on that. One is, I'll just, again, more for your reading later, but actually computers do quite well at forecasting, and we have several studies that have been published over the years here demonstrating reasonably unambiguously that computers tend to do better than even expert human beings. However, it turns out that when we pair computers with humans, we can do even better. But just want to convey that actually computers can do quite well at forecasting and often better than humans. So please consider that. And from a leadership perspective, if you're blessed to be in that role, please consider how it is that you can support the rest of us who are trying to support you by allowing us to take reasonable risks and see how it is that we can present better information to you to support your decisions. So again, forecasting tends to be the stumbling block, and please, consider whether it's really as obviously terrible as you might think, or if we can actually help. Okay.
You did have one question
Oh,
just about the type of graph you were showing before with the diamonds. If you knew the name of that type of graph, Simon was asking.
Wonderful question. Thank you, Simon. And thank you for typing that in immediately and being able to help us figure out where we were so we could address the question. Yes, so I always think about the Lucky Charms commercial, but this is not called the Lucky Charms chart. This is actually called a forest plot. And the idea behind a forest plot, if you've seen it in the sort of peer-reviewed medical literature, is it gives us, especially in evidence synthesis, is it gives us an understanding about how it is that we're doing across subgroups or across different studies or things like that. The idea, as the name suggests, is that it allows us to see the forest as well as the trees. So we're not looking at just geography one, we can actually see the whole system and each tree, as it were, within the system. So this is called a forest plot, and thank you for that question. Okay, so now we're going to shift gears dramatically and talk about an unexpected application. So we're going to start with, what do we think of when we think of quality and health and healthcare? And the Institute of Medicine gave us a perspective on that a while ago, and I happen to be partial to the ARC, or Agency for Health Research and Quality page, that describes the 6 domains or dimensions that the IOM did, but in one easily digestible page that I can keep on my phone if I ever forget. And the dimensions are safe, effective, patient or person-centered, timely, efficient, and at the bottom here we have equitable. And I like to think, although I don't know, and maybe some of you on the audience do, I like to think that equity was placed not at the bottom of the list because it was an afterthought, but because as human beings, one of the biases we have with our memory is that we tend to remember the last thing we heard, and so maybe that was why equity was placed at the bottom. If anyone knows the answer, by the way, I would love for you to let me know. So, what is equitable? Well, equitable is the definition here in slightly larger font, is that our quality does not vary by personal characteristics such as gender, ethnicity, geography, and socioeconomic status. And of course, we can place other things in there like primary spoken language or other things. So there are a lot of dimensions where we would like to say to someone, you don't need to adapt. We should be able to adapt to you. We don't want you to have to move to a different state or county. We don't want you to have to change your age or your ethnicity. We should be able to adapt our delivery system to ensure the highest possible quality, taking into account how you present yourself. So we're going to go on to another poll question here.
All right. Okay, in this poll question, we'd like to know, how do you assess or address healthcare equity in your system? Your options are 1, we don't, it's not a priority at this time. 2, a health equity group that discusses opportunities. Option 3 is a scalable quantitative approach to finding opportunity. Option 4 is formal equity evaluation or optimization embedded in major initiatives. And 5 is other. We'll give you just a few moments here. And again, we are recording today's session. You will have access to the recording and slides starting tomorrow. All right, looks like the votes are starting to slow down. I'm going to go ahead and close that poll and share our results. So we're kind of across the board here.
Yes.
No major, I guess 27% is our majority here with a health equity group that discusses opportunities, but it's not a clear winner, I'd say. What would you have expected to find here?
I am really impressed by the 24% of equity evaluation and optimization is embedded in major initiatives. This is the first time we've seen something like that. And kudos to you who have shifted up that side of the curve already. And we're seeing, what I'm seeing in this chart is what we call a bimodal distribution. So we have people who are not really focusing on equity as a top priority, or they talk about it but don't really have a scalable approach or have it embedded into their major initiatives. And then we have another group of people who have taken it all the way to the other side. By the way, for those of you who have ever done work in medication adherence, you'll often find this to be the case. So we'll often say, oh, well, patients are adherent to their medication 50% of the time, but if you take a closer look, often what we see, especially for asymptomatic chronic conditions, is that we'll see there's a group of super adherers and a group of non-adherers, and really nobody in the middle. It's a little bit like having 2.5 kids. None of us really has 2.5 kids, and we see here, we're starting to see we have sort of super adherers or super equity folks, and then we have people on the other end of the spectrum. And I hope this discussion addresses both of those ends. And Belle, I saw a question from you about cultural competency, and I'm hoping that some of what we're going to talk about here feels relevant to you. So thank you for that question.
We did have a question about how many respondents we had to the poll just now, and I think we had a ballpark around 60. Just so that Aaron, that's your answer.
Thanks, and I did notice. I think that was our lowest response rate yet, and I don't know how much of that was because people just weren't sure, and that's commonly the place. Okay, so I'll just point out, at least for me personally, Sarah mentioned that I came to Health Catalyst from Kaiser Permanente, and perhaps all of you know, but if you don't, Bernard Tyson, the CEO of Kaiser Hospital Foundation Systems, actually passed away not long ago, very recently, a little over a week ago now, and is one of my heroes in this space, along with many of the people that he brought on board. And so it's somehow timely for me that we're talking about this in a way, hopefully, that he might be proud himself. Okay, so where are we starting from with AI? And I think it might be fair, especially recently, that there's a deep concern that our AI will actually exacerbate disparities. On the left-hand side here, we have something that was published by on Ron Wyden's site, talking about how he wanted to make sure that going forward, people did not experience what his parents experienced trying to buy a house in the 1960s, where his family was discriminated against. And then more recently, we've had a publication in No Less Than Science that talks about racial bias in algorithms, sort of sadly and ironically, specifically designed to help us focus on our most vulnerable members, was actually introducing bias into the process. And both of these are worth checking out. The links are at the top. There are many others. But I think the place that we're starting from is there is grave concern that AI will make the world worse. And where I hope we get to together in this discussion is that that could absolutely be the case. We have specific examples we can point to. But just like self-driving cars being made safer, and just as if we may want them to respect our preferences and goals and what we count of as good, we have an opportunity, if we think about AI as augmented intelligence and think about what it is that we would like the computer to do for us, maybe we can think about how we design it to actually help us improve equity, and specifically how it can help us at the leadership level in organizations. So for anyone who noticed, you might have seen that the people who won the Nobel Prize in Economics this year did so for applying randomized controlled trials to the field of economics, and specifically public good projects. You might say to yourself, how could somebody almost in 2020 win a Nobel Prize for something that we have used in health and healthcare for at least 70 years? And you'd be right to question that, but I'm still glad that they did their work. Worth checking out their work if you haven't. And now what I'm going to do, though, is take actually something out of economics, and the journey that we'll go on is how can we take an idea that came out of economics and apply it to help us think about health and healthcare equity. So Sarah, when you see this picture, and if I were to tell you that this was a heat map of where it was that we had achieved financial equity in the world and where it was that we were struggling, what things pop out to you where we see that we're doing well or not well? And is there anything that surprises you in this map?
I mean, I'm assuming green is good. Typically,
Green is good.
red is
Yes.
bad.
Yes.
So it looks like the southern areas of Africa are hurting the worst in this area. But it is interesting that the U.S. is in a pink shade. You'd I think expect that we'd be in green. Canada's lit up green, and interesting that some areas of Eastern Europe are lighting up really green too. That's surprising to me,
isn't it? So thanks for that. And what we're looking at that's behind the colors, and deep apologies for those of you who are red-green colorblind. I wanted to stay true to the original map and do realize that we're biased against people with red-green colorblindness. But what we're looking at here is a map of something called the Gini Index. And the Gini Index is named after a person that's about 100 years old now. So maybe one of you can win the Nobel Prize for applying a 100-year-old technique from economics to health and healthcare. There's still the opportunity, I think. But what the Gini Index does is it says how equally how are we distributing wealth within a country. So Sarah, your interpretation was spot on. This isn't saying that people in Southern Africa make less money than people in Canada, or for that matter, people in the United States make less money than people in Canada. What it's saying is within the United States, within Canada, within Sweden, within South Africa, how equally is our financial resources distributed. And just to call out a couple specific ones there, we have South Africa, which does in fact, at the time of this report generation, have the deepest inequity at a Gini index of 0.63. United States, you were right to call out as not in the green zone, is at 0.41. And then we start to see some of the ones that we would expect, like the United Kingdom and especially Denmark. We tend to think of the Scandinavian countries as being quite equitable. I was once yelled at by someone who actually lived in the Ukraine, saying that this is insane, that the Ukraine could be the best in the world, but at least by this measure it was. So I should probably take Ukraine off and leave it at Denmark. But these are some specific numbers that we're looking at across the globe. Now, here's the leap that we're going to make. It turns out that the Gini index is mathematically and algebraically linked to something that if you've ever built a predictive model, you know and love, and that's the area under the receiver operating characteristic curve. So that is a measure of how well can we separate, for instance, between two people who are leaving our hospital today with heart failure, which one is going to be readmitted. And if we correctly identify the person who gets readmitted, then we get a bonus point. And if we say the person who is going to be readmitted doesn't get readmitted, then we lose. And we summarize that as what's called the area under the receiver operating characteristic curve. But it turns out that AUROC, or C statistic, or C index, as you might have heard published about or used, is linked directly to the Gini. And what that allows us to do then is ask the following question. Should we restate what counts as equitable in the context of health and healthcare quality to the predictive model that we wished we couldn't build? So if we're trying to identify who's going to be readmitted to the hospital, we hope we can identify things like the total number of medications they're on, or the recency of their illness, or their access, their access to care, because these are all things that we can act upon and do something about. We hope we're not able to predict their readmission on the basis of things like gender, ethnicity, or geography, or socioeconomic status. So what we're doing here is, rather than looking at a list of countries like the United States and Canada and Ukraine, we are looking at a list of possible measures that a healthcare organization can have. And there are a lot on the list. I'm just going to highlight a couple. Hemoglobin A1C less than 8 is probably something you're used to. Hypertension control, colorectal cancer screening. Hopefully these are measures that at least some of you recognize. And what we've done is we've built a predictive model using features that we hope that we could not use, like ethnicity, like primary spoken language, and so on, and then converted that to a Gini, which I said we can do through simple algebra. So as we look at these measures for this particular organization, they can actually feel somewhat good. It turns out that the worst measure they have has a Gini index that's actually better than where the United States Gini index is for financial and economic equity, right in the range of what the United Kingdom has been able to achieve. And some of the least equitable measures still are in the general range of Denmark. And we find this fairly repeatedly in different organizations that we've had the pleasure of working with around equity. We tend to find that actually we're doing okay. Now, there are some possible challenges. Maybe we're not collecting the data correctly and the like. But the important thing is to be able to make that leap for ourselves of thinking about equity as the predictive model that we wished that we couldn't build. Because as soon as we do that, we have the entire toolbox of AI and machine learning and predictive analytics open up to us so that we can turn that toolbox into a tool for good. So not only is the AI not making disparities worse, we can now leverage those same tools, that same toolbox, to help us understand where might an organization focus. I've highlighted 3 here because these are ones that are commonly focus areas for equity for organizations, but often on the basis of not really being able to leverage data or the tools that we have in this space. Once we've ranked things like this, we can actually take it a step further. And if any of you are familiar with the concept of feature importance, what we'll do next is layer on top not just how would we rank our ability to deliver equitable care per this measure, but what's actually contributing to the inequity. So for instance, 3 features we could consider: the geography, the race, and the age. And if we look only at those and you look for the longest red bars, then you can see this measure number 844 has the greatest geographic inequity. If we look at age, we see an inequity around measure 435. And these are a little bit silly, but it's just a way, they are real measures, but it's just a way where hopefully you can see quickly not just where do we have the greatest inequity overall, but what is driving or what's associated with the inequity contribution. And I'll zoom in a little, because the focus for a particular organization that we had the pleasure of working with was actually around hemoglobin A1C control. And specifically, if you're familiar with this measure, you can be less than 8, less than 9, and so on and so forth. They had selected hemoglobin A1C less than 8 as a focus area. Why? Because they had hoped to improve racial disparities. And what the data opened up is, yeah, there is opportunity to improve equity within hemoglobin A1C less than 8. However, it was principally being driven by age. And so if their focus, and again, this is a value judgment on the basis of the organization, if their focus was really on racial inequity, then maybe they should look somewhere else. And maybe the answer is there are no opportunities for racial inequity, in which case they should feel great. Or maybe they say, no, until this gets to 0, we don't feel satisfied and we're going to keep moving ahead. Again, that's a value judgment, just like whether you want to go to a restaurant, and if so, which one. So let's take one step further then. It turns out that the measure immediately below hemoglobin A1C control actually had the greatest racial inequity across all measures that this organization had. And that measure had to do with antidepressants. There's several measures around antidepressants. This one in particular was the continuation phase of antidepressants. And so the machine, the AI, has not only been able to identify for us where do we have inequities generally, but given our preferences, given our values, given where we want to focus as an organization, if our focus is on race disparities, then perhaps we should look at antidepressant continuation. What's really cool is that for this organization, it turned out that they had another focus area. So one focus area was improving health and healthcare equity. Another area that we had as a focus was let's improve mental health and wellness. And so now the computers actually helped us find the perfect interrelationship that we would always hope to be able to find within an organization, and especially as leaders, or for that matter, anyone else in the organization that is struggling with initiative overload. Here we've actually been able to combine focus areas for 2 major initiatives, 2 major aspirations to the organization. We see both that if we want to improve racial-driven disparities in care, we can focus on antidepressants, and not just any antidepressants, but specifically the continuation phase. And if we want to focus on mental health and wellness, we now have somewhere a guiding principle to tell us where. Should we focus on inpatient care, outpatient care? Should we focus on schizophrenia? Should we focus on early diagnosis? There's so many ways that we could focus. And thankfully, in this case, we had the perfect collision or synergy, however you want to think about it, of our aims actually coming together. And doing so, not because the AI told us what to do, but because the computer's really good at crunching through the hundreds of different measures, the hundreds of different dimensions that we might be able to consider, and bringing to the surface and visualizing and making transparent to us all what it's seeing, not so that we defer judgment, but actually so that our judgment can become even more important. Our value system becomes even more important because we're able to have those discussions transparently and leveraging the data assets that we have tried so hard to get our members and our clinicians and everybody else to donate for our benefit. So just to review some of the topics that we've talked about, and then if you have any questions, try to address some of them. So we know AI gets a boatload of attention at the point of care and service. It's super sexy. Everyone's excited. I hope that by the end of this, you can see some opportunities for how it is that we may be able to leverage those same tools in the space of leadership. Where as an organization should we focus? How should we allocate resources? What's reasonable when we set up goals for accountability and the like? Because it turns out that many of the tools that we know and love at the point of care and service actually apply just as well at the leadership level, although admittedly from a very different lens. If you're in the leadership position, what you can do is to help support attempts to leverage the data in the kinds of ways that we've been talking about, and support your analytic and technical staff trying to figure out how we close the very real gaps today. This is not easy. We can easily represent a readmission risk with an electronic health record. We can easily represent the willingness or the predicted probability of a member being willing to commit to quit smoking in a care management or population health tool. It's difficult for us today to be able to represent some of the ideas and the techniques that we've been talking about within our standard business intelligence tools. But we're not going to get there until leaders get behind the effort and start pushing us and the industry in that direction. And with that, we are done, but Sarah, you have at least one other question.
I do. I'll go ahead and launch that right now. Okay, so this is our final poll question before we dive into the Q&A time. While today's webinar was focused on the important role that AI can play in leadership decision-making, some of you may want to learn about the work that Health Catalyst is doing in this space, or maybe you'd like to learn about our other products and professional services. If you would like to learn more, please answer this poll question. And I'm going to go ahead and leave that open as we dive into these questions. And we have about 5 minutes right now. Were you able to stay on for 5 minutes extra if we need to?
Sure, if there are questions.
Okay. So we're gonna.
Can we actually go to that last one that you were just on, the A1C?
This one. Yeah. From Paul.
Yeah, go ahead.
I was just saying it was from Paul, and Paul's question was, for A1C, is the age disparity a contributor for the younger or older population?
Paul, that is such a terrific question. So many people that I have spoken with assume, and this is true for hypertension as well, that the challenge is in the older populations, for instance, in A1C and hypertension. And what we've seen routinely at different organizations is it's actually the older population that achieves the highest levels of controls there, and there are all kinds of hypotheses why. And other things that we've seen, although you didn't ask this directly, is that we see that it's actually different across different race and ethnic groups. So we want to look at not just how is age contributing, it turns out, but what is it that, for instance, we may be able to see in the attainment of hemoglobin A1C control in younger Hispanic populations at some organizations, and apply that, for instance, in whites. So it's a wonderful question and really great to do a deeper dive.
All right, maybe we'll move on to this next question that just came in from Christina, because it seems to also be about the HbA1c.
Yeah.
So Christina asks, on the slide and discussion about the HbA1c and anti-D, this appears that you're correlating HbA1c people with those that have anti-D. Am I even saying that properly?
Yep, antidepressants.
Okay, but isn't it possible the populations do not overlap directly? So how can you deduce that this elevates a single population? In other words, a person A may have a high HbA1c but not be depressed and require antidepressant medicine. Wouldn't one have to do a second level of analysis to form that deduction?
Yeah.
She said, perhaps I missed a step in the analysis.
Yeah, you know what? Christina, that is a terrific question, because what it highlights is that I was not at all clear in my description, so thank you. When we're looking at the Gini index here, we're actually not assuming any overlap, although we can look at overlap across the populations. So just like we weren't assuming overlap between the countries of South Africa and the Ukraine or Canada. So the nice thing is that we're able to look at each of these populations and each of these measures either independently or in conjunction. And let me give you a specific example of why that matters so much. At one organization that we looked at, their greatest opportunity was actually in long-term high-dose morphine equivalent or opiate utilization. And it was driven principally by age. And to the hemoglobin A1C question earlier, it was actually the older people who were struggling more with long-term higher dose opiates. But the organization wasn't quite sure what to do with that, not because they didn't have any hypotheses, but because the population was so small. And so they actually decided to focus their efforts disproportionately on larger populations like hypertension, at least in the short term, because they saw there also opportunity and the ability to test what might work. Whereas in the opiate population, it was so small that they weren't sure how to design tests to achieve improvement. So hopefully that helps. If I've not answered your question, please just put back in your question, and I'll try to address it in a better way. Thank you.
Okay. I'm going to circle back to this question from Belle to see if we fully addressed it. So she had asked, does or can this AI take cultural competency into account when making recommendations to overcome any racial bias introduced by zip codes or other metrics like that?
So Belle, if you're still on, I would love to know if you feel that we've started to address this question, but I think this, but I think we've not actually. We've seen how AI may be able to be used for the benefit of achieving equity, but what we've not directly addressed is how it is that within the context of, for instance, achieving hemoglobin A1C control or reducing readmission or something like that, we're exacerbating bias or disparities. And the science article that I had brought up earlier has a nice description about how it is that we can think about assessing for bias. And then what we can do is to start to design not just our predictive models, but our interventions in such a way that we test for how it is that we can optimize for equity. What might be a specific example of that? One that I've worked on is trying to consider when is the best time to do population health outreach, and what types of languages should we take into account for that. And so we can design a predictive model that helps us understand which of our members or patients might be amenable to the intervention, but then explicitly look at that through the lens of race or primary spoken language or geography or something else, and actually implement that as part of our optimization plan. And that's a wonderful way to be able, I hope, to more directly address the very real concern that you raised. So if that helps, please let me know. If I missed your point, please let me know that too.
Okay, I think we're just going to do one or two more.
Okay.
As we are past the top of the hour now.
Okay.
Dan had asked earlier, does the Gini index measure wealth inequality or income inequality? He says he could see that being an important distinction.
It is an important distinction, and it's been used both ways. And I'll just point out I didn't put it here, but there's a wonderful literature in the education space around how they have used the Gini index to some effect as well within the space of education. So just to be clear, Gini is a general mathematical concept that essentially has to do with how equally is something dispersed in a population, and it can be applied in many places. It's most commonly applied in the econometric space, but we've seen great work done in education. I'm hoping we'll see more in health and healthcare as well. So thank you for that question, Dan.
Okay, I think we're going to call this our last question from Simon, who said, some researchers use the P% rule to account for fairness. Could you comment on the validity of that metric?
Oh, I would need a little more clarification on this one. Simon, if you're still on, maybe you can say a little bit more, or we're also happy to field questions via email and then post those. So happy to do that, but that may be the only way that I can address the question. I'm sorry.
Okay, I think we're going to go ahead and wrap up on that then. Is that all right?
Okay. Yep, thank you.
Okay, well, we want to thank Jason for taking the time to present to us today, and we also want to thank all of you for joining us. Please do us a favor and complete the short survey as you exit the presentation. Your answers will help us to deliver more valuable content in the future. Can you click ahead just a couple slides? It'll show our next webinar. All right, there we go. As a reminder, by midday tomorrow, you will receive an email with links to an on-demand recording, the presentation slides, and a transcription. Our next webinar, The Biggest Healthcare Trends of 2019 and What's to Come in 2020, will be held in 2 weeks on Tuesday, December 3rd, and we hope that you will join us for that. On behalf of Jason and all of us here at Health Catalyst, thank you for joining us today. This webinar has now concluded.